breast radiotherapy is the standard of care after surgery for most women with early breast cancer. That's been established through many studies and reviewed by the Early Breast Trial Collaboration Group. We know if you give radiotherapy after breast-conserving therapy, then overall you halve your overall risk of recurrence, but 2/3 reduction in the risk of a local recurrence for early breast cancer, depending on what your risk is. So for years, the standard of treatment was to give a 5-week course of radiotherapy, so giving a dose of 50 gray in 25 what's called fractions or doses. Previous studies in Canada and the START trial here in the UK showed that if you gave a slightly bigger dose each day, but a slightly lower total dose, what's called hypofractionated radiotherapy, then the sort of 3-week course was just as effective at reducing the risk of recurrence of breast cancer, and actually resulted in slightly less long-term toxicity for women, such as breast shrinkage, hardening. And so that was established as the standard many years ago. Now, this study was trying to push further. We did another study called the FAST study, trying to work out what the best sort of compromise was between sort of toxicity and long-term outcomes as far as recurrence goes. So, and that then led to the Fast Forward study, which is this study. So in this study, there was several thousand patients, and we wanted to find a regime that would be at least as effective as the 3-week regime in terms of reducing the risk of local recurrence and also long-term toxicities. So we didn't feel the study needed to be better, the results better. We thought, well, if you could concentrate and give the treatment in a week with no inferior outcomes, that would be a very good outcome for women and healthcare systems. So trying to find the best dose is always a compromise between toxicity and outcomes. So there were 3 arms in this very large study. We tried to have a sort of pragmatic design so that it was relevant to the population of women globally with breast cancer. So anyone who'd had either a wide excision or a mastectomy with some nodal surgery, who'd had clear margins and were generally well, they were randomized to 3 arms, either the standard of care, which is the 40 gray and 15 doses over 3 weeks, or 2 experimental arms, one giving 27 gray in a week and one giving 26 gray in a week. And the primary outcome was local regional relapse with sort of usual secondary outcomes of regional relapse, metastatic disease, toxicity as well. And as part of the study, we did some sub-studies. So we did acute toxicity in 2 groups of patients to see whether there was less toxic, more toxic, or no more toxic. Some people are worried that the shorter regimes will cause what they call burns, but they're not burns, they're just an extreme radiation reaction. We know there shouldn't be, but we needed to prove it. And also we did a nodal sub-study because for the first part of the recruitment, we didn't allow a separate nodal field for various reasons, but we've now completed that study as well, but we haven't got the long-term results of nodal radiotherapy yet. So there were 4,100 patients randomized into the study, so about 1,300 in each arm. And overall, we got the primary outcome we wanted, so it was a non-inferiority study. We reckoned we'd have about a 2% local regional relapse rate, and we wanted to be sure to exclude more than a 1.8% increase in that relapse rate. But what the study showed was as expected, a very low general rate of local recurrence. So the 40 gray arm, there was 2.1% risk of local regional recurrence. Numerically, in the 27 gray and the 26 gray, there were actually less recurrences, but statistically, no difference in the recurrence rate, and very few women relapsed, which was great news. And that was the same whether it was local regional relapse, local relapse, distant relapse, mortality, all causes, mortality, breast cancer. There was no difference between the 3 arms, which was great news. The long-term toxicity, which we assessed via clinicians and patients and photographs, then whatever method was used, then the 27 gray arm in 1 week was slightly more toxic in the long term, not very toxic, but a few percent more women and clinicians reported toxicity such as breast hardening or any change in breast appearance. But the 26 gray arm and the 40 gray arm were what we call ISO equivalents. So there was no difference in the toxicity in the long term. In the short term, then we found that all the regimes were very non-toxic as far as skin reactions and tiredness goes. So the 1 week schedules were generally slightly less side effects. The side effects came on quicker and went away sooner. So a very mild reaction for most women. So overall, a very successful trial result. So the non-inferior as far as local relapse goes, less toxic in the short term, quicker to give in the short term, which is better for healthcare and for women, just done and dusted in a week. And the long-term toxicity at 5 years was equivalent. So we feel we've met our primary endpoint, and this should become the new standard of care. So as far as should it be implemented now, then normally there's quite a lot of thinking about should we implement it, what should we do? I mean, this study was done in 97 centres across the UK, which was most of the radiotherapy centres. So everyone had got used to doing this regime and seeing anecdotally for themselves that it was no more difficult to plan, no more difficult to deliver, and reduces capacity hugely on radiotherapy machinery. Breast radiotherapy accounts for about 30% of utility of radiotherapy. So if you can reduce that from 15 doses to 5, that's a huge reduction in fractionations and a huge reduction in costs. Just in the UK alone, that would be a £40 million a year saving to commissioners and taxpayers, which can go somewhere else. Now, I said it normally takes ages for results to be implemented. This was nothing to do with COVID, this study, but the results were published just as we were being hit by the dreaded COVID. And so it was implemented very quickly. There was a group of people got together to form an international consensus as to was this a reasonable regime to give to patients. And because we'd just published in the Lancet and already published 3-year toxicity data before that everyone felt that not just because of COVID, but it should be accelerated into standard of care. All women having breast or chest wall radiotherapy should be recommended the 26 gray in 5 fractions over a week rather than 40 gray. And in many countries, they're still giving 50 gray. There seems to be a real reluctance to move to hyperfractionated radiotherapy for sometimes perverse financial incentive reasons, maybe, rather than outcome measures, but that's for healthcare systems to sort out the funding of treatment. And as far as nodal radiotherapy goes, then the outcomes are expected to be the same. The primary outcome of the study is patient-reported outcome for lymphedema. So hand on heart, we haven't got that data yet. But certainly if you want to extrapolate, which you may choose to do at this time of COVID, then the breast cancer cells won't be any different, whether they're in the breast or in the lymph glands in the lower armpit or the higher armpit or in the supraclavicular fossa. So we don't expect the alpha beta ratios or the fraction sensitivity of the cancer to change depending on where they are. And other than brachial plexus, there's no different tissues further up than there are in the breast or the chest wall. But certainly if you look at what the total dose in 2 gray equivalences of 26 gray, then it's less than 50 gray, it's probably about 44 gray. And we wouldn't expect that to cause any damage to the brachial plexus. So certainly some of us, including myself, have introduced this for pretty much all women having post-operative radiotherapy, get 26 gray in 5 fractions. Unfortunately, because of COVID, we haven't been able to present this at many international meetings, but hopefully forums like this will help. The paper's already published in the Lancet in April, and there's open access for everyone to read. And through, we're about to have a Royal College of Radiologists sort of consensus meeting fairly soon, where most of the participating centres and non-participating centres in Fast Forward will take part and come to conclusion, hopefully, that this new hyperfractionated radiotherapy should be the standard of care. Now, we've had some quite encouraging correspondence from around the world. Certainly some areas think, well, it doesn't actually save any more lives, but radiotherapy resource is very scarce in many countries. And you have to use 15 or 25 doses on patients and you've got scarce resources, then many women aren't going to get access to radiotherapy. But we've had correspondence from from Asian countries and African countries saying, well, if we had a 5-fraction regime, then a lot more women would have access to standard of care post-operative radiotherapy. You know, most radiotherapy planning nowadays is getting much harder. There's lots more complex treatment. There's a lot more check-in on set. So if this schedule shortens the duration of 30% of radiotherapy usage, then it should open the doors for more complex, time-consuming regimes in well-off countries and allow access in poorer, with less access countries to give standard radiotherapy. Okay, so there will be some criticisms. People will go, well, where's your subset analysis? But so few patients relapsed. It was sort of 31 in each arm or less. Subset analysis would be pointless, but there was no difference in any subsets. And where's your 10-year results? Well, we haven't got any 10-year results. We've only got 5 years. But from all other previous radiotherapy studies, if there is a toxicity difference at 5 years, then yes, it gets slightly bigger at 10 years. You get more late toxicity as time goes on. But normally, if there is a difference at 10 years, there's also a difference at 5 years. So we'd be very surprised if there was a meaningful difference in toxicity later on. But obviously, we're still collecting data and we'll be able to present that later on. But I wouldn't have concerns that we're storing up trouble for women by moving to this regime now. Hopefully that's been useful for everyone. The paper's available, I said, in the Lancet in April. So, all the details are in there. And next year we'll be publishing the nodal sub-study radiotherapy outcomes.